It's unknown whether the severe acute respiratory syndrome coronavirus can be transmitted through breast milk. The only report of testing found no virus in the maternal milk of 6 patients. However, droplet transmission could occur through close contact during the feeding. Thus, mother with confirmed case or symptomatic mother with suspected COVID-19 should take precaution to prevent transmission to the infant during feeding, whether by EBM milk or by formula by another caregiver until the mother has recovered. So can SARS-CoV-2 be acquired in utero? The virus has not been detected in cord blood, amniotic fluid, or placenta. Maternal viremia rates appear to be low, 1% in one study, suggesting placental seeding and vertical transmission are unlikely. We'll go through the clinical manifestation. Are the sign and symptom of COVID-19 different in children than adults? The symptoms of COVID-19 are similar in children and adults, but fewer infected children have symptoms. COVID-19 appears to be milder in children than in adults, although severe cases have been reported in patients with comorbidity. Fever and cough are the most common reported symptom in children. In the case series from United States, complete information about symptoms was available for 291 children. 56% had fever, 54% had cough, and 13% had shortness of breath. 73% of children had at least one of these symptoms. Although some children presented with only gastrointestinal symptoms, laboratory findings in children with confirmed infection were variable. Approximately 1/4 had leukopenia and 3.5% had lymphopenia. Procalcitonin was elevated in 64%. CRP was elevated in 20%. Chest radiograph may appear unremarkable or demonstrate bilateral consolidation. So are children at risk of having severe COVID-19? Although severe cases of COVID-19 in children reported, including fatal cases, most children appear to have mild or moderate disease and recover within 1 to 2 weeks of disease onset. Infants less than 1 year of age and children with certain serious underlying condition are at great risk of severe disease. Other medical conditions that may increase risk of severe disease listed here, like blood disorder, chronic lung disease, chronic kidney disease, endocrine disorder, and severe obesity. Why COVID-19 appear to be less common and severe in children compared to adults is unclear. Some considerations are less vigorous immune response to the virus in children versus adults. Cytokine storm is thought to be important in the pathogenesis of severe COVID-19 infection. Another explanation is that viral interference in the respiratory tract of young children leads to lower viral load in children. Finally, the receptor of the virus is the ACE inhibitors, which may express differently in the respiratory tract of children compared to the adult. How often do children with COVID require hospitalization? A minority of children with COVID-19 require hospitalization, and very few require intensive care hospitalization. Intensive care admission were more common among infants less than 1 year of age and children with underlying condition. Thank you. I finished with my part, and we'll go now with our senior nurse, Nurse Katrina.
Good afternoon. Good day. Pleasant day to everyone. Today I'm here to discuss the pediatric patient flow in emergency department and the use of visual triage in the early identification and isolation of acute respiratory infection cases for the control of hospital outbreak infection in reference to COVID-19. Visual triage Played
played
vital
in the isolation of the patient at the entry point.
visual
Visual
area
area with nursing station located in front of the entrance of the emergency department
assessment of
for
each patient.
assessment of each patient according to acute respiratory form scoring. In this regard, we were made compulsory policy for each and every patient to pass through visual triage, allowing only to pass those who are critically ill. Assessed by visual triage nurse according to respiratory triage score form, upon their arrival to emergency department visual triage area, we encourage them to perform hand hygiene, teach them about cough etiquette, and offered surgical masks both to patient and companion. The visual triage nurse will fill up the checklist for acute respiratory illness form, given the score, place a stamp, and if score is less than 4, he or she will go to Canadian triage room or the main triage area. If score more than or equal to 4, the patient were sent to screening center via mobile carts if available, or strictly following the yellow broken lines leading to the way to screening center for continuity of care. There are colored solid lines found on the floor of the ER. Solid green line is the way for non-respiratory patients. Solid yellow line is the way for respiratory patients. Solid red line is the way for suspected, confirmed COVID-19 patients for admission to COVID ward or for transfer to assigned COVID facility outside the hospital. If any patient will pass through without assessment from visual triage, the registration staff, doctors, and nurses will not entertain these patients and will immediately send them back to the visual triage area for assessment. In other words, no patients will be seen or entertained by the registration doctors without acute respiratory form scoring for safety purpose. Now let's begin with part A, the exposure risk. There are 5 parameters we need to ask in order to arrive to the score of 3. First, we can ask about any travel history outside Saudi Arabia for the past 14 days. Visiting or being a resident of high-risk areas for COVID-19 for the past 14 days. Close physical contact, any close physical contact, confirmed case of COVID-19 for the past 14 days. Exposure to camel products, direct or indirect, and if the parents or the ones directly taking care of the patient is working in a high-risk healthcare facility. Now we proceed with the part B, clinical signs and symptoms. Each symptom will be given a score of 1 for each. Symptoms include fever, cough, and shortness of breath. All patients attending emergency room, except those who have immediately life-threatening conditions, were screened at the entrance using the predefined scoring. Identified acute respiratory illness patients scored more than or equal to 4 are evaluated immediately inside the isolation negative pressure room. If the physician confirms that the patient as a suspect meets the case definition and epidemiological link, nasopharyngeal swabbing is indicated and will be performed by a trained nursing staff. Note that all swabbing and all aerosol generating procedures must be performed exclusively inside negative pressure room. Then we will proceed to the post-collection of COVID-19 sample in the clinical pathway. In the event that the isolation negative area is occupied, an area separated from other patients called respiratory zone will be the temporary area for acute respiratory illness patients with non-life-threatening condition while waiting to be swabbed or waiting to receive aerosol-generating treatments. Our respiratory zone here in our hospital has 5-bed capacity with spatial separation up at least 1.2 meter between each patient. All healthcare professionals are required to adhere with the standard precaution plus properly donning a full PPE when entering and perform the doffing correctly to prevent the spread of infection. Hand hygiene is performed as needed. Inside the respiratory room, we also post visual alerts, such as covering your mouth with nose and tissue with a tissue when coughing or sneezing, dispose the tissue in the nearest receptacle immediately after use, perform hand hygiene, prevent overcrowding in clinical areas to reduce the risk of transmission between patient and staff. Proper donning and doffing is strictly implemented and given emphasis to all staff for strict compliance. The medical frontliners, which include doctors, nurses, radiologic technicians, and essential workforce, are composed of housekeeping, patient relations, and security personnel, are working together as a team to facilitate patient and staff safety carried out effectively. Thank you so much. Now we'll proceed to the next speaker.
Wafaa.
Most of hospitalized patients will need oxygen therapy. Might improve. Okay. Okay. So most of hospitalized patients need oxygen therapy. These type of patients on conventional oxygen therapy might improve and discharge or may need intubation and ICU admission. By discussing the first module of American Heart Association regarding oxygenation and ventilation and recommendations, we'll find out how to risk mitigate oxygenation and ventilation in patients with COVID-19. Okay, and these are my reference. Objectives to review oxygen therapy and non-invasive ventilation in COVID-19, to discuss risk mitigation during oxygen therapy, and to have quick glance at our pediatric emergency COVID-19. How to implement infection prevention and control measures for patients with suspected or confirmed COVID-19. Instructions for patients. This is very important, really. Experts is learning more about the role of asymptomatic children and those with mild disease in spreading COVID-19. Instructions should be given to caregiver and the children themselves in a nice way to avoid the stress and panic. As Katrina mentioned, we teach them when they arrive to hospital, plus all the advertisement covered by the government, MOH, MSD, and everybody all over the globe. About hand washing, not touching surfaces or face, eyes, and nose, mouth. We teach them how to wear masks, educating them regarding social distancing and how to be safe. If they keep distance of not less than 1.5 meters or 2 meters even, and to practice cough and sneezing technique. The recommendation to put surgical mask from the point of entry to emergency, in emergency is mandatory for everybody. Implementation of infection protection and control measures for all patients, contact and healthcare workers. Regarding contact precaution, apply all what mentioned plus the PPE, personal precaution equipment, and we have to know about donning and doffing. Airborne precautions when performing an aerosol generating procedure like nebulization, suctioning, changing tubes, or these things should be done under strict airborne precaution in isolation room, negative pressure room, and full PPE with N95 mask. Okay. COVID-19 guidelines of surviving sepsis campaign stated that 19% with hypoxic respiratory failure. 14 of them require oxygen therapy, and 5% will require intubation and ICU admission. So we need to consider precautions in using conventional oxygen therapy and other technique for oxygenation and ventilation. So we need to consider precaution in using these things, which is very important, really. Risk mitigation of oxygen therapy in this season or crisis of COVID-19, we have to risk mitigate oxygen therapy, we have to apply the use of method and equipment with least aerosol generation. Like we have the rule of no bagging at all, except if we are in the negative pressure room or isolation room, preparing for intubation, you can use the sealed fitted mask without bagging, and use the lowest flow necessary to achieve an oxygen saturation of 90%. Nasal sprung 5 liter maximum, and non-rebreathing mask can be used. We come to the non-invasive ventilation or HIFO, the high flow nasal cannula. It has a higher risk of generation aerosol, need full airborne precaution and full face mask and filtered circuits equipment, preferred to be done in the negative pressure room. Of course, we don't use or we don't go for the HIFO or non-invasive positive pressure ventilation by BAB and CBAB. It requires higher level of attending approval. It is recommended to avoid it if cases are confirmed. But let us to find out in a lot of the surge or increasing number of suspected cases who we need to do nasopharyngeal swab, aspirate in a negative pressure isolation room. With all of these numbers increasing suddenly, you might not have enough places or equipment. So why not to use the high flow nasal cannula or the non-invasive ventilation in certain situations, in selected patients, in selected situations with very high airborne precaution and attending high level of attending approval. These exceptions, like those who are in the situation of do not intubate or chronic patients, neuromuscular disorders, usually at home or in the centers of care using the CBAB, but they are having suspected COVID-19. So they need support for their non-invasive ventilation by filter or pressure manipulation. Again, the exacerbation of bronchial asthma patient or congestive heart failure. If they are suspected COVID-19 and they need support for oxygenation and treatment of the failure or exacerbation with the ventilation and suctioning and nebulization, you might put them under strict airborne precaution and can be used somehow with all precaution we mentioned. Okay, the high flow nasal cannula is recommended over the non-invasive ventilation. What mechanism the high flow nasal cannula working at? Simply or in simple way, high oxygen flow will wash out all dead space from epiglottis and above, what is known as extrathoracic dead space. So wash out CO2 in exhalation and fill the space with oxygen. Better success rate with mild and moderate ARDS, high flow nasal cannula. Increase comfort, decrease risk of transmission to healthcare worker with strict airborne precaution. Use minimal flow, and we use the minimal flow of like 30 liter per minute. May have less aerosol generation to maintain saturation above 88 to 94. Proper size and fit of nasal cannula is needed. Loosely fitted surgical mask or face tent. You need gas source of blender, flow meter 40 to 60 per minute, and analyzer humidifier. These patients on HIFO should be assessed hourly and in couple of hours to make sure there is improvement in oxygen sat and oxygen requirement is reducing or toward weaning of that. If not, do not delay intubation if there is no improvement. we may have more information in the future about this HIFO and non-invasive ventilation as what happened with SARS. Quick review of non-invasive ventilation. It provides ventilation assistance by providing positive pressure at low level, unload respiratory muscles, lung volumes. Successful non-invasive ventilation attempts require alert patient, capable to maintain airways, and no facial abnormalities. Type of setting, spontaneous mode or pressure mode. Peak airway pressure range from 8 to 20, CPAP or beep range from 5 to 20. The rule of thumb, if you need more ventilation, more CO2 removal, adjust peak air pressure. If you need better oxygenation, you adjust CPAP and PEEP. Just to let you know about the previous slides, we have to know make sure that there is filter for the CPAP and it should be added if not available. So in this starting setting, we need to typically start pressure, inspiratory pressure and oxygen 100%, okay? And titrate to effect. Requirement for COVID-19, if IO2 21 to 100%, CPAP and BiPAP, filtering of exhaled gas, full face mask. Limitation, potential aerosol generation. Device limitations, those who are using it at home, they might need filter or added pieces or oxygenation. Some lower end devices cannot provide a circuit configuration. So when to escalate for invasive ventilation? Generally, if any patient having worsening oxygenation, hypercapnia, septic shock, acidosis, altered level of consciousness, an index can be used, the ROX using the FiO2 and the saturation of the oxygen to calculate this index when to start. But actually in this COVID-19 time, we don't have to delay. It's better to have a plan to electively intubate, not improving patients or so. This is just to say that most, if not all, of pediatric emergency physician are PAL certified. Yes, the recommendation from AHA is to intubate in an ICU setting to decrease the exposure. But everybody should know in the time of crowdness or when we need to ask all physician or medical and paramedical to help in oxygenation and ventilation, we should know all these steps. The same algorithm, it's in the open sites of AHA. If failure to improve this patient on HIFO of 40 and more, or no improvement in non-invasive ventilation of FiO2 60, so it's better to not to delay the intubation. Stick to this algorithm, starting with PPE. The room should be personnel for the intubation, to reduce the exposure, reduce the number, and apply all of this algorithm. Most important, don't forget for giving time for donning, wearing the PPE, you have to do the non-bagging ventilation or oxygenation. And to make sure that limit the personnel during intubation, start high quality CPR, ventilate with oxygen using bag mask device with filter, and tight seal. If not available, use non-rebreathing mask. Attach to monitor or defibrillator whenever it is available. Analyze rhythm. If VF or VTAC, give shock, but don't delay again the intubation. If asystole or PA, continue CPR, prioritize intubation, both chest compression for intubation, and if it is delayed for anything or difficult, don't forget you have the LMA, laryngeal mask airway, or bag mask device with filter and tight seal. connect to ventilator whenever available, and do the rest of the steps. Finally, I just would like to share with you that we have a clear system and pathways in our organization, very clear teamwork and pathways. We are trying our best to be very organized and coping with all of these things happening, caring about kids, healthcare worker. We agreed to do the pathway. Dr. Roaa, our ID consultant, will talk about the pathway. But just to have a quick tracing of a patient coming through emergency door, as our senior nurse Katrina mentioned, will be done all the assessment we triage. If scoring 4 or more, he is for to do nasopharyngeal swab. This to be done in a negative isolation room. We have in the emergency and preventive medicine and screening area. The other thing, we have a pathway of those 6 months and below or above. 6 months and below of age, they should come directly to our ER and to through the triage. And more than 6 months going to the screening area. That was done to reduce the exposure. If swab done and patient is asymptomatic, can go home, they will be followed by our supportive group in the hospital with close monitoring and asking about their situation. If suspected and the swab came negative, or they are symptomatic in sort of febrile, shortness of breath, distress, cough, or chest X-ray showing some inflammatory, infiltration, then will be admitted under care of the COVID team. Luckily enough, we have very organized pathway. We have very strict infection prevention and control measures. Virtual clinic also reducing the exposure. So we have only patients who need to come to be seen in emergency. Then we apply the pathway. If need admission, we'll go to the COVID surgical ward under care of COVID team. If discharge will be followed, as I mentioned. We have respiratory or suspected case zone in emergency to be kept with. Aerosol generating procedure in emergency is prohibited at all, and the aim is not to delay intubation if anybody needed by the PICU personnel and a clear pathway. I would like to say thank you for all, and wish you safety, and just to say our Prophet Muhammad, peace be upon him, said, none of you truly believes until he wishes for his brother what he wishes for himself. I wish for all people around the globe to be safe and healthy. Stay optimistic. If you don't have work or shift, stay at home. Thank you. Now, Dr. Roaa will start.
Assalamu alaikum. I will start my talk, or I will complete the talk of Dr. Eyad started and Dr. Wafaa and Katrina regarding the management and our plan in King Fahd Arm Hospital. The slide, okay. Slide, I think not yet is clear. Slide, listen. Okay, Bismillahirrahmanirrahim. I will start my talk by introduction and the fact about children, treatment, and then the special condition like newborn, and our experience in the King Fahd Hospital. As Dr. Eyad talked about kids, they are very most common incidence of pediatrics to get infection of COVID-19. There are a lot of published data in many countries, like in USA, the percent of pediatric infected is only 1.7 of the total infected in USA, and less than 1% in China, and also in Italy it was 1.2%. As also in Saudi Arabia, there are very low cases of pediatric to have infection. In the last report, before 2 weeks, they said only 32 pediatric population, they were positive for COVID-19. They are less severe, which require less admission. The previous slide, please. They are less severe, which require less admission to the ICU. Total number of patients admitted to the ICU in the literature in China and in the CDC, in USA, in Italy, they round between 0.58 to 2% of the patients of pediatric, they require ICU. And also they have very low mortality, only 4 reported deaths in pediatric, 1 in China and 3 in USA, where are confirmed to have COVID-19, but they have underlying conditions. And regarding the symptoms, almost the same, but they are different in presentation. Like the fever, they are common in adult, which count 93 compared to pediatric 73. The cough also 54% in pediatric and 80 in adult. They have less myalgia and they have no sore throat, about 24%, with the less presentation of the abdominal pain and diarrhea, about 13% if we compare to adult, 31%. So my next part about the management. Before starting the guideline, all the guideline was published, used to assess healthcare practitioner to select the best available antiviral therapy for the COVID-19 infection according to the best available and current evidence. This guideline not intended to replace the clinical judgment, but rather to complement it. We should involve the family for treatment plan, and we should have high index of suspicious, and we should think about other differential diagnoses of fever like meningitis, urosepsis, bacteremia, and pediatric. There is no evidence from randomized control clinical trial that any potential therapy improved the outcome in patients with either suspected or confirmed COVID-19. There are no clinical trial data supporting any prophylactic therapy. More than 300 active clinical treatment trials are underway through the CDC, through MOH, and clinicaltrial.org. Regarding the management, we have general management or symptomatic management if the patient, they need hydration fluid, if they need oxygenation. And as antibiotic, we use paracetamol, and we should avoid ibuprofen and other NSAID. And the other thing, it is antiviral therapy. Why we are not using NSAID? Because there is a lot of uncertainty about it. No clinical or population-based data address the risk of NSAID. But there was negative effect of NSAID was raised by a report of a few young patients who received NSAID early in the course of infection and experienced severe disease. Given the absence of data, the European Medicine Agency, EMA, and WHO do not recommend NSAID to be avoided when clinically indicated. This is a diagram. It is really important and can explain the virus life cycle. As we can see, the virus, the SARS-CoV, it is a single-strand RNA, it is envelope virus. It targets the cell through the S protein to bind to the ACE2 receptors in the host cells, and also use the TMPRSS2 receptors to facilitate the viral entry to the host cells. Once the virus entry, go under endocytosis and membrane diffusion and uncoating, and use the RNA transcriptase to form the polypeptide, then using the protease to use non-structural protein, and use the most important step, the RNA-dependent polymerase, to use the mature or structural protein, and underwent assembly and exocytosis. So all the antiviral therapy, it is target these life cycle, especially prevent the viral entry like some medication, and also endocytosis like chloroquine. And we can use the inhibit the proteases or the RNA dependent, which is really novel and promising treatment. The first treatment I will talk about, only medication was approved for pediatric and approved by Ministry of Health of Saudi Arabia. The first one is hydroxychloroquine and chloroquine group. They are blocked, the mechanism of action, they block the viral entry by inhibiting glycosylation and host receptors, pyrolytic processing, and endosomal acidification, and also have effect on immunomodulatory effect through the inhibition of the cytokines production and autophagocytosis and lysosomal activity in the host cells, as we use in the SLE patient. And we have to avoid the chloroquine in G6PD, used with caution in diabetic patients because it can induce hypoglycemia, and these patients, they have to adjust their insulin requirement and can cause fatal cardiac arrhythmia. The other medication, it is Calitra, or it's combination of two medications, lopinavir and retrovirine. It is HIV medication. They demonstrate in vitro activity against the other novel coronaviruses via the inhibition of protease activity. But there are a lot of side effects, mainly the severe gastric upset and gastritis, and the current evidence does not support using it as a monotherapy, usually used as combination with chloroquine and hydroxychloroquine. And there are a lot of interaction between this medication and the enzyme inducer. But also it is contraindicated in renal and hepatic impairment. The next one, the famous medication now, a lot of media and social media report about promising this medication. It is remdesivir. It is RNA polymerase inhibitor, but unfortunately not currently available in Saudi Arabia, and also not FDA or SFDA approved. And it is investigational drug used in critical cases as compassionate use in some medication, in some cases. And we cannot use if patient they have multi-organ failure, if the patient need of introp, creatinine clearance less than 30, and if the patient have dialysis or hemofiltration and can cause significant transaminases. So it is contraindicated to use with patients with very high liver enzyme, or you cannot use with combination with other medication. This medication, tocilizumab, it is like immunomediator used as bind the L6 receptors, so prevent the L6 receptor activation and inhibit the signaling, so can control the cytokine release syndrome, which really play a role in the disease critical patient. So this medication need dose adjustment with patients with hepatotoxicity, and we should perform IL-6 level and other inflammatory marker testing before starting, like CRP, ferritin, D-dimer, or we should watch for infusion reaction. There are some other medication not approved by Ministry of Health, but was written in literature. They are used in pediatric, like steroid, but it's not recommended unless there are other indications like in COPD, and because as all the data showed, there are increased mortality in patients with influenza and delayed viral clearance in patients with MERS-CoV infection. And there are other combination, azithromycin and hydroxychloroquine. Some study was poor methodology, non-control. There is no control sample, and the sample was very small patient. They noticed there is more rapid resolution of virus detection when they use this combination, but they have very high side effect, which is prolongation of the QTC, and combined use may potentiate this adverse effect. And interferon beta, it is effective reduce MERS-CoV in vitro and has resulted in good outcome in animal models of MERS-CoV infection. But the study for human was non-conclusive. In China, they use interferon gamma in patients with severe disease and also as ribavirin combination. If you want to see the more study, you can just enter the WHO site at the clinicaltrial.gov. You can see more than 300 trials ongoing and with best evidence, inshallah. Regarding the newborn, there is no evidence for intrauterine vertical transmission of COVID-19 from infected pregnant mother to their fetus. They are well known that the infected mother can transmit the COVID-19 virus through the respiratory droplet during the breastfeeding, as shown in the literature in the China. COVID-19 is not known to cause fetal congenital anomalies. So, the baby, once born, we have to prevent the infection as much as we can. If the mother should deliver by SVD or CS, we should immediate separation of the baby from the mother, and we will do washing for the baby as fast as we can. Direct breastfeeding is not advisable and should be avoided. Either the mother is suspected or confirmed till we clear the infection. The EBM option, express breast milk, is the option for feeding. We have to take a precaution measure strictly to be allowed during the expression of the milk. The mother should wash her hand and breast, wearing face masks during the pumping, using a clean breast pump, clean the surface of the milk collection container, and the best one is the mom, she shouldn't feed the baby indirectly, and we should assign another person to feed the baby. And the MBS nasopharyngeal swab of the baby should be done after 24 hours of delivery. If the mother needs to be treated, we should note that not all medication are safe for neonate, especially for the lactating mother. Like the hydroxychloroquine, we can use chloroquine, not advised for G6PD, and Kelatra, it is not also advised for pediatric in the lactating mother. Our experience in King Fahd Armed Force Hospital, Dr. Wafaa started. They are allocation of the respiratory zone. Just I will focus on something in as inpatient of pediatric. The manpower of the COVID team plan, we have the pediatric emergency department team, we have pediatric COVID team, pediatric ID, and PIT consultant with other subspecialty of pediatric, and of course with cooperation with the family medicine in the screening center and in the family medicine clinic and the infection control. So we assign the pediatric surgical ward room to suspected cases, and we have a negative pressure room assigned to confirm cases or any case need nebulization or any arousal generation procedure. We have 2 rooms in the surgical ward assigned as in-house on-call room for the COVID-19 resident, and we have a locker room which was assigned as changing room. A team of 2 to 3 consultants and 6 residents are teamed to provide coverage for 2 weeks until the end of the pandemic. The pediatric infectious disease and the pediatric ICU team are on call if they need any advice. PPE huddle for 10 minutes implemented in the daily handover, and we are using SPA for the handover. We are discharging patients if they are negative and they are stable, and we are giving them follow-up in the virtual clinic, appointment, and daily phone call by the pediatric COVID team. And this is our pathway created by the department. We are using, of course, the case definition of the Ministry of Health, and then we are dividing the patient that arrive to our hospital in 2 groups. Either if they are newborn, delivered from the suspected or confirmed COVID-19 infected mother, we should follow the newborn protocol and inform the pediatric infectious disease for clearance of these children. And the pediatric ER for evaluation, they will see the patient, all the patients less than 6 months, or any patient with risk factor like hematological disease, chronic lung disease, or chronic kidney disease, or any patient with congenital heart disease. And they are going directly to the ER for evaluation. More than 6 months, they are screened in the screening center, and if they need advice or help from the pediatric, they will contact them directly. So if the patient, they are said the definition and he was stable, he will be wearing surgical mask and perform hand hygiene, and we are doing the sampling, and if it is negative, we are discharged home with home isolation for 14 days. And if it is positive, we are admitting the patient directly to the surgical ward, which was assigned for COVID cases, and be managed by the COVID team, pediatric COVID team, with consultation of pediatric ID, if any clinical deterioration. And we'll repeat the swab. If it is negative, he can be discharged home. If the patient he was unstable, he will be directly to the ER for stabilization, and we will consult the ICU team directly, and they will take further management for the child. Of course, we should notify the site manager, infection control, and they follow the patient and they give their advice. Also, we create a doctor order to be easy for the COVID team to be followed. We put our precaution and the appropriate vital sign for age, and we put question should be answer no if can be discharged safely, and if the doctor they want to add more order, and this is our vital sign according to the age. For in ICU, also we create pathway to be easy to follow. We allocate 2 rooms, one for SFD, if the patient she delivered by SVD, or if CS, it will be in the OR7. Of course, we'll avoid skin-to-skin contact with the mother. Baby will be separated immediately at birth. We initiate stabilization, resusc as needed in negative pressure room, and we'll apply airborne precaution if suctioning or any tracheal intubation. Baby transferred in a double-walled incubator, preferred 2-in-1 model, and will admit in ICU isolation for a negative pressure room. If the patient is well appearing, we will do testing after 24 hours, and he can discharge home if the mother is negative and the baby PCR is negative. And if the patient is ill, and he will go for the management, and even if it is negative PCR, and he will stay in negative pressure after the clearance of the COVID-19. And also the pediatric ICU, they have their own diagram for management of COVID-19 to be followed. If the patient unstable, they are using the BRAM score. They divided the patient to high risk, mild, moderate, and critically ill patient, and they will be managed as according to their severity and their vital sign. So to conclude, even though the children tend to have mild form of COVID-19, does not mean we should ignore those who have the disease. We need to take measures to prevent them becoming infected, but especially for a mother to neonate, if the mother she had positive COVID-19. We also need to bear in mind that viruses can persist in feces long duration after they are absent from the nasopharyngeal secretion. As reported in the literature, they can stay 28 days after negative MBS swab. So especially the mother who's doing diaper change or the caregiver. Thank you.